Let's start our discussion on mechanism of labor now. So what is normal labor? First we'll see, next we'll see mechanism of labor. So if you see in a normal labor, the lie of the the lie of the fetus will be longitudinal, right? About all this I discussed previously, okay? So longitudinal lie, and the presentation will be cephalic presentation, that is the head will be coming downwards, and the presenting part will be most commonly vertex part, okay, and the position will be left occipito transverse, which is the most common position, and the denominator is occiput, right? So about this all we know clearly before. So first what we need to say is 7 cardinal moments. What are these cardinal movements? This one we need to understand now mainly in this video. The 7 cardinal movements are movements which occur while fetus is traversing the maternal pelvis. Now fetus is trying to come out from the maternal pelvis. So the movements which the fetus shows is called as cardinal movements. Okay, so first let us see the left occipito transverse position, where the sagittal suture is in transverse diameter of pelvis. I mean, if you see from the below, the sagittal suture is in the transverse diameter according to the pelvis, okay, whereas the posterior fontanelle is towards the mother's left side. Posterior fontanelle, mother's left side. According to us, it will be on right side, okay. So coming to the first cardinal movement, the first cardinal movement is called as engagement. So first there should be engagement. So what is going to engage here? Let us see. Engagement occurs when largest transverse diameter of presenting part has passed through pelvic inlet or crossed the pelvic plane. So that is nothing but the largest diameter is called biparietal diameter of fetus, right? It is 9.5 centimeters, right? It should pass the pelvic brim or inlet, okay. So then that is called as engagement. So the time of engagement in the case of primigravida is 38 weeks, whereas in multigravida it will be in the onset of labor, okay. So coming to clinically, engagement may be ascertained by per abdominal examination, palpate above the pubic symphysis. So sometimes we can do clinical examination by palpating above pubic symphysis, okay. So one thing you need to remember, that what is zero station and see, if you draw for example, this is a pelvis, okay, this is pubic symphysis. So exactly at the center here you will have the zero station. Above 0 all are negative, like -1, -2, okay, and here everything are plus. Below 0, +1, +2, okay. These are the causes. This is called as stations, which you need to remember. So coming to examination, if you do per abdomen examination, above pubic symphysis, for example, let me draw head here, okay. So above pubic symphysis is 5/5 of the head is palpable, that is with all the 4 fingers. So actually we'll palpate like this. So 4 fingers and thumb, okay. So 4 fingers plus thumb, then you can feel the fetal head, okay. So with this 5 fingers you can feel the fetal head, then you can say 5/5 of the head is palpable, okay. Coming to Leopold 3, head is ballotable, or you can say it is freely floating. According to Leopold 3rd maneuver you will say, and according to Leopold 4th maneuver you will say the fingers converge below the presenting part, okay. Coming to convergence, if you put your both fingers, like for example let me draw your both hands like this, they will converge here. So coming to per abdomen, 4/5. 4/5 is the 4 fingers can feel the fetal head, and next coming to 3/5 means only 3 fingers can feel the fetal head, okay. So here in this cases you will say head is not ballotable according to Leopold 3rd maneuver, and according to Leopold 4th maneuver you will say fingers are diverging, head is fixed, it has already gone inside the pelvis but is not engaged, okay. So if 2/5 or less, then only you will say the head has got engaged, that is only 2 fingers. If you palpate you can feel the head, or with 1 finger, or of course if you will not palpate the head itself, then you can say the head has already gone into the pelvis. So coming to per vaginal examination, so from below, if you do per vaginal examination, the position of fetal head with respect to ischial spines, here will be ischial spines, right? So on per vaginal examination, if you see the leading point, the lowermost part of fetal head, the number represents the distance from ischial spine in centimeters. So for example, this is the ischial spine. So from here to pelvic outlet, there's 5 centimeters difference, and from ischial spine to pelvic brim there is 5 centimeters. So in total you can say 10 centimeters. Okay, so coming to example, you take station -3, means from ischial spine -1, -2, -3 here, right? So station -3, the head is 3 centimeters above ischial spine, and engagement you'll say the station of fetal head is 0 or below it. Okay, so you will say the head has got engaged only when the station is at 0 or below it. That is exactly at the level, when the head is exactly at the level of ischial spine or below it, then only you say head is engaged. If the above ischial spine the head is there, then you will say it is not engaged. Okay, so that is the leading point. Take the ischial spine as a leading point. Ischial spine is a leading point. So engagement confirms there is no cephalopelvic disproportion at the level of inlet, of course, because if the head has come into the pelvis, then you can clearly say there is no CPD. So coming to synclitic and asynclitic engagement, what is this? Synclitic, asynclitic. So let us see what is this. Synclitic engagement is a sagittal suture of the head of pelvis. Okay. So synclitic position means the head is in the LOT position. Okay, so that is and also you will see the distance between the pubic symphysis and sacral promontory between the head. For example, this is pubic symphysis here. Okay, this is the head here, and on the back side there will be sacral promontory like this. So you will measure the distance between between sacral promontory and head, also between head and pubic symphysis, and you will see that the fetus is in LOT position, that is the occiput is in left occipital transverse position. Okay, so coming to asynclitic, before seeing asynclitism, you should see that asynclitism is divided into two types. It is a anterior asynclitism and posterior asynclitism. Okay, so anterior asynclitism means the anterior parietal bone is felt first from per vaginal examination, and sagittal suture is deflected towards the sacral promontory, also known as Nigglis obliquity. I'll show the diagrams, don't worry. So they are most common in multiparous female, anterior most common in multiparous female. So in the posterior parietal bone is coming first in perivaginal examination, and the sagittal suture is of course deflected towards pubic symphysis. So just opposite. If you get first anterior parietal bone, then the sagittal suture will be deflected towards sacral promontory and Nigglis obliquity. Here in the posterior parietal bone, it is felt first, so sagittal suture is deflected towards pubic symphysis, and this is also called as Litzmann obliquity. So this is Litzmann and this is Naegele's, and this is most common in nulliparous female. Okay, so these things you need to observe. I will show the diagram just now to you. So you can see here this is a normal sagittal suture, and here you can see this is the anterior asynclitism, that is anterior parietal. You can see the anterior parietal bone is first front, and the posterior parietal bone you can see it is more towards the sacral promontory. And here you can see the posterior parietal bone is coming first, and the sagittal suture you can see it is more near to the pubic symphysis. Now let us discuss about engaging diameter. So what is engaging diameter? It is divided into the transverse diameter and the anterior posterior diameter, also called AP diameter. Okay, so transverse diameter is always of course biparietal in the case of fetus, head, right? So it is equal to 9.5 centimeter. Coming to AP diameter, it depends on degree of flexion of head, right? If the head is well flexed, that is well flexed, this already we discussed. If head is well flexed, then it is vertex presentation. So there will be sob diameter, that is sub-occipitobregmatic diameter. If the head is deflexed, then there will be occipitofrontal or sub-occipitofrontal diameter. And if the head is partially extended, then There is bro presentation. In the bro presentation there's mento-vertical diameter. Okay, in the case of fully extended head there is face presentation, and there is submento pragmatic diameter. Okay, and the mento-vertical diameter is the longest diameter, like 14, right? And submento pragmatic is 9.5, and suboccipitofrontal right, it's like about 11.5, something like that. Okay, and suboccipitopragmatic is also 9.5. Okay, so this diameters I think you can check out in the previous videos I discussed already. Okay, so engagement occurs with marked asynclitism in platypelloid pelvis. This is important. Engagement occurs in marked asynclitism in especially platypelloid pelvis. Okay, so most common cause of non-engagement of head in premigravidate term is occipito-posterior position. So what is the most common cause of non-engagement of head in premigravidate is occipito-posterior position, OPP. So whenever in this position, then it will be most hard non-engagement, and second most cause maybe CPD, and the third most cause maybe placenta previa.